This is session four. As usual, the slides will be sent out at the end, as will the recording. So look out for that. We're going to be talking about the 1115 waiver under which New York runs its entire Medicaid program, and then we're going to be talking about HR1 impact. So this is going to be the federal cuts class as well as the Medicaid waivers class. Two somewhat related but mostly distinct topics. But Beginning with the 1115 waiver, I feel like when I started out in New York healthcare politics, like everyone, I occasionally heard about the 1115 waiver as this thing that New York State was doing. And basically, it was always reported on as just sort of like, I didn't know what was being waived, why it was called that number, but I knew that it generated a bunch of magical federal money that the state could use to do sort of healthcare stuff. And Over time, as I studied it more, I developed the view that that's basically right. Basically, the 1115 waiver is a way for the state to get more federal Medicaid money, but the details are more complicated. Um, so let's talk about Medicaid waivers in general. Um, the reason we have Medicaid waivers is because the actual Medicaid Act, which is Title 19 of the Social Security Act, it's like the title after Medicare, which is the title after Social Security, has a bunch of requirements on how states can operate their Medicaid programs, most of which are about guaranteeing participants' rights. And so, for instance, there's a requirement that different groups of enrollees have to be eligible for comparable services, meaning basically the same services, that they have freedom of choice of which provider they use, that Medicaid has to be the same statewide. It can't vary from region to region within a state. And then more restrictively, there's a list of benefits that a state has to cover and a list of benefits that it can optionally cover. So, like dental might be optional, for instance. And then there's other stuff it can't cover, at least under without a waiver. So there's stuff that, if the state wants to fund highway repair through Medicaid and call it a Medicaid benefit, it can't do that. So there's a restriction. And likewise with eligibility, there's populations the state is required to cover if it wants to operate a Medicaid program at all. There are populations that it has an option to cover, and then there are populations that it can't cover. So it can't, maybe it can't cover people who earn too much money or something like that. And so waivers basically allow you to waive these requirements. So, for instance, what if there's a requirement that you offer comparable benefits to everyone, but like, what if we felt like people who are suffering from HIV actually need more help, like they need care management or they need a social worker to help them coordinate with other benefits or something. We want to offer that benefit to that specific population, but we don't want to offer it to everyone else. Um, or freedom of choice. Under the Medicaid Act, you can use whatever Medicaid enrolled provider you want. You can go to any doctor who participates in Medicaid. But if we want to put people in managed care plans, we have to restrict that and say you can only go to the doctors that are in your managed care plans network. Um, and obviously, benefits, we might want to cover some benefit that isn't part of the normal Medicaid package. Like we might want to fund inpatient rehab for people with substance use disorder, or we might want to fund some kinds of home care that aren't part of the traditional package. And then eligibility, a state might go either way. It might say we want to cover more people who wouldn't be eligible under the basic requirements, or a state might say, we actually want to cover fewer people or require people to pay a premium. Like a red state might say, we really want certain categories of Medicaid beneficiaries to pay a premium, stuff like that. And so the purpose of Medicaid waivers is to basically to allow states to waive these requirements to experiment with their programs. Now, um, there are various waiver authorities. Sort of the three big ones are 1115, 1915C, and 1915B. And all of these are their numbers because they're specific numbered paragraphs in the Social Security Act. So they're the numbers of provisions in the Social Security Act that say something like the federal government is allowed to waive the following requirements of this statute for a state under the following circumstances. 1115 demonstration waivers, and that's like the main waiver we're going to be talking about today is New York's 1115 waiver, are sort of the biggest, broadest, most general kind of waiver. They allow the federal government to waive almost anything it wants about Medicaid or, in fact, Medicare for demonstration purposes. And so the original intention here was to sort of say, if some state has some really innovative idea, like they want to test for the first time whether home care is a better way to provide long-term care than nursing homes, or they want to test a managed care plan. We want a provision that allows the federal government to do that, to demonstrate whether it works, and then maybe Congress will come back and make that happen in the whole program. And for decades, 1115 waivers, from 1965 to the mid 90s, 1115 waivers were pretty rare, and they were really used for that kind of demonstration purpose. But now they've become since 1994, basically the federal government, sort of in the wake of the Clinton healthcare reform failure, wanted to give states a lot of room to experiment on healthcare. And so 1115 waivers became much, much more common. And today there are more 1115 waivers than there are states. There are 65 active 1115 waivers. Some of them are like pretty specific, like in the way I was talking about, maybe you have an 1115 waiver that covers just people with HIV and, offers them specific benefits of a specific kind. But others, like New York's, are comprehensive. And basically, the state goes to the federal government and says, look, we want to run our Medicaid program in different ways, in like a whole bunch of different dimensions. So we want to make people go into managed care, and also we want to expand eligibility for home care, and also we want to provide extra coverage for children, and like we want to offer special services to foster parents. The whole Medicaid program is going to be one big 1115. And so we're going to waive a bunch of things. And that's the situation of, New York runs our Medicaid program that way. Vermont does, Arizona does, a few different states. And the so just reviewing, there are basically three flavors of waiver, although there are a lot of minor ones. 1115 is the broadest authority. It's the main one we're going to be talking about. There's also 1915B waivers, which is a special waiver authority Congress added basically just to let states do managed care. 1115 can also do what 1915B does. And that's how we do it in New York. We do managed care through 1115 authority, but 1915B is narrower. And 1915C, it's sort of the same deal. Waivers are used but in this instance, it's specifically to offer home care. And a lot of states will have instead of doing what New York does, where there's a very large home care program and anyone in Medicaid is eligible, states will apply for like a 1915C waiver to give home care on a small experimental basis. And they'll say, we're going to have elderly people who are transitioning from a nursing home up to a total enrollment of 5,000 people will be allowed to get home care and no one else will. So that's the kind of thing you can do with a 1915C waiver. Um, these waivers are a really big deal. There are a lot of them, and at this point, most of Medicaid is operated under waivers. So this is the point of this pie chart, which is from MACPAC, the Federal Medicaid Advisory Board, and shows total Medicaid spending. 75% of it is happening under one waiver authority or another. So you got your 1915B waiver, your 1915C waivers, and then 1115 demonstration waivers account for more than half of Medicaid. And then state plan, which is sort of Medicaid without a waiver, is only a quarter of Medicaid programs at this point. And so really, Medicaid has changed from being a program that basically works in a fairly standardized way across all states to one that is like very varied by state since the Clinton administration sort of opened the floodgates on waiver authority. Now, but the other thing to mention is like even though New York operates a Section 1115 demonstration, that doesn't mean our Medicaid program doesn't also cover what a vanilla state plan Medicaid program would cover, right? Like we still pay for people to go to the hospital and go to the doctor just like other states. It's just that we do that within a program that's authorized through this waiver instead of through the state plan. All right, so I've talked a lot about waivers, and now you know why they're called waivers, what is being waived, why you would want to waive some federal requirements, why CMS might let states do that. But I actually have not explained the money, right? So like I said at the beginning, the most common use of 1115 in New York politics is we'll say, we got $7 billion from the federal government through 1115 to fund, payments to hospitals or whatever. And so how is it that that Medicaid waivers generate money in this way? The answer has to do with budget neutrality and the budget neutrality requirement around 1115 waivers. So basically, the requirement is like, you might wonder, like once you hear all the stuff that can be waived, you might wonder, could a state just use an 1115 waiver to like put everyone in the state on Medicaid and do Medicaid for all? And the answer is no. 1115 waivers have to be what's called budget neutral for the federal government. And so what that means in very rough terms is that the federal government to approve the waiver has to decide that the federal government won't be spending more than it would without the waiver. And so obviously that wouldn't be true if we put everyone in the state on Medicaid, right? Like they would be spending more because they'd be covering more people. And so, roughly the situation is that when the state applies and says, we want to expand coverage to this population, we want to add this benefit, they have to go to the federal government and say, look, and we're going to save money. Like our managed care program is going to be cheaper than our old program was, so we're going to save money. And so this is gonna cost you less than or only as much as it would cost to just have vanilla Medicaid. The key thing here, and so this involves like a very high stakes calculation around what the state would spend in a hypothetical universe where it wasn't awarded the waiver. And this calculation is especially complicated because, for instance, in New York, we've run our Medicaid program through an 1115 waiver since 1996. So the hypothetical universe where we didn't have the waiver is actually quite remote, right? Like there is sort of, it's been a long time since we didn't have an 1115 waiver. And so the calculations involve a lot of guesswork and a lot of negotiation, but just a really simplified example of how this might work is like the state and the federal government agreed that without the waiver, the state would have spent $5,000 per enrollee in Medicaid. So what that means is the state can't spend more than $5,000 per enrollee um, in with the waiver, right? So it's capped, or technically speaking, the state can spend whatever it wants, but the federal government won't match spending above $5,000 per enrollee. And so then if the state spends less than $5,000, let's say it spends $4,800 per enrollee, then it has what are called budget neutrality savings. So the state might ask, okay, like now we're under what we would have spent otherwise. Shouldn't we get something out of that? Then this can be a lot of money pretty quickly. So if a million people enroll and we're spending $200 under the hypothetical without waiver scenario, then we've got $200 million to play with. And the key thing about 1115 waivers and really why they're so useful to New York and elsewhere is that the state can then spend those savings on not only on sort of normal Medicaid stuff, but on stuff that would not ordinarily be covered by Medicaid, which is the acronym is costs not otherwise matchable, or CNOM. And so the state can apply to the federal government and say, look, we think in the next 5 years we can hold our costs below what they would be without the waiver by, $1 billion. And we want to spend those $1 billion to expand eligibility to a new population, to fund safety net hospitals more than we would otherwise, to do to fund home care for the elderly, or food for people who are nutrition insecure, need food, all sorts of things. And so that's really the magic of the 1115 waiver, is that it generates this potentially free and very flexible source of funding for the state if the state can convince the federal government that it is going to spend less than it would without the waiver. So in other words, 1115 waivers really have two distinct uses. One of them is to waive stuff, to waive federal requirements on Medicaid. The other is to generate money by going to the federal government, making the case that we are spending less than we would be without the waiver on normal Medicaid stuff, and then spend the savings on other flexible Medicaid stuff. And so how have states spent this extra money, costs not otherwise matchable budget neutrality money? That has changed really significantly over the course of like the history of Medicaid. So before 2010, a really common use in New York and across the country was to say, okay, we're generating these savings. Like maybe we've gone to managed care, and so we're spending less than we used to because the managed care plans are holding down spending. We want to use that to expand Medicaid eligibility to a larger group of low-income adults. So that's how we're going to spend the money. That became less relevant after the Affordable Care Act passed, because now the federal government is sort of covering a lot of those populations through vanilla Medicaid. It does still get used. And so, for instance, New York did continuous eligibility for children, meaning some children between ages of 0 and 6 who might not have been eligible under previous rules were eligible. We did that just this year, just in 2024 through an 1115 waiver. Another very popular use of 1115 stuff is inpatient treatment for people with substance use disorder. That's like normally not part of Medicaid because Medicaid has very tough restrictions on inpatient mental health spending for historical reasons involving how bad psychiatric institutions used to be and the federal government not wanting to pay for that. So that's another common use. But then um, after the Affordable Care Act passed and coverage expansions were no longer the most relevant thing, a very common use for 1115's funding was basically to give more money to safety net hospitals through a form of payment called a Delivery System Incentive Reform Program, or DSRIP. And so New York did this in a big way in the 5 years before 2020. This relates to something we were talking about last class, where certain kinds of hospital supplemental payments became less useful as states transitioned to managed care. The federal authority became more restrictive. Um, DSRIP was a way to get around that and to do a lot more supplemental payments in the managed care era. And then that in turn became less relevant during the Biden administration because the Biden administration liberalized other safety net hospital stuff. And so the Biden administration was really encouraging states to fund uh, services related to social determinants of health. So the idea here, and we'll talk about it more in the New York case, is if someone is showing up in the ER a lot because they don't have access to food or to stable shelter, or they don't have good transport to go to doctor's visits, those are all social determinants of their health. Normally, Medicaid can't pay for those because they're not properly medical, but under 1115 authority, the federal government has been willing to let states do that. Um, Now, I want to say if a state has, let's say, $1 billion of budget neutrality savings, that doesn't mean the federal government is giving it $1 billion. It means it has $1 billion of Medicaid spending authority, but it, as the state, still has to fund half of that. So it has to come up with its own 500 million, and then the federal government will match it. And so it would be great if you could find a way to have the federal government actually fund the whole thing. And there is a mechanism within the 1115 process that makes that possible, called designated state health programs, or DSHPs. This is not to be confused with DISH, which is just disproportionate share hospital spending, which we talked about last class. This is a separate thing. So the idea of a DSHP is basically, let's say the state is spending $100 million on something that is definitely not Medicaid, but is like totally healthcare related or arguably healthcare related. So let's say like we're spending $100 million a year on anti-smoking ad campaigns. So that's good for health. Under 1115 authority, the federal government can allow a state to designate that health program as a Medicaid program and get the Medicaid match on it. So the 100 million we're spending, we were already spending. Now it's Medicaid matchable, so 50 million of that spending is coming from the federal government. And that frees up $50 million of state money, right? Like the state still has to put in their 50 million, but it frees up $50 million of state money to fund other things in Medicaid. And so the 1115 waiver both allows the state to spend more money than it would otherwise on Medicaid programs that would not usually be matched under Medicaid, and it also allows states to get extra money for stuff, get extra money to fund those expenses. This is all extremely negotiable and discretionary, though. So, like, how much how much budget neutrality savings there are is like very much, it's very sensitive to what you treat as the baseline, what you treat as the realistic alternative hypothetical where you don't have the waiver. And so the amount of money that a state can get through 1115 is very much in the eye of the beholder. And what should be eligible is also potentially controversial. Like, what's a good way to spend 1115 money? And so it's important to understand about every 1115 waiver that it is very much negotiated between the state and the federal government, where the comes in and says, we think this waiver is saving us a ton of money. So we have like $20 billion of budget neutrality savings, and we want to spend it all on, highway repair because we feel like you can't have social determinants of health without highways. And the federal government says, no, 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 we disagree with your calculation. We think you only have $5 billion budget neutrality savings. And don't be ridiculous. We're not going to let you spend Medicaid money on highway repair. Come up with something more health related. And they negotiate often for like an extended period of time. Like, these negotiations can last years. And then they come up with an agreement about how much money there is and how it's going to be spent, which is embodied in a long, like a 300-page PDF document with what are called STCs, special terms and conditions, that the state agrees to in exchange for federal approval. So this is a lot of the state federal politics of Medicaid happens through these negotiations. Okay, and so that was a long lead up to finally talk about New York's 1115 waiver. New York's 1115 waiver is important to talk about now because it is currently up for renewal. It was basically the current version of the waiver was approved in early 2024 and is due to expire in March 2027. And so back in 2024, we were negotiating with a presidential administration and federal government that loved Medicaid and loved Medicaid creativity. And now we're negotiating with fascists who hate Medicaid. And so we're going to be in a very tense negotiation with the federal government about the 1115 waiver we have now. And so I'm going to talk about what's in the waiver now and what might change. So basically, New York got a really good 1115 waiver out of Biden administration, although it took a couple of years and a lot of controversy to negotiate. New York got 6.7 billion in budget neutrality savings. The majority of that is going to, not quite the majority, but almost half of that is going to what are called health-related social needs programs. So basically, that means social needs like the need for food, shelter, transport that are not properly medical care, but help determine people's health. The state got $3.7 billion of approved sort of Medicaid spending on those things and infrastructure related to those things. We also got $125 million for a health equity regional organization, which is basically the United Hospital Fund is going to coordinate stakeholders to collect some data about health equity. Not going to talk about that one. We got $2.2 billion for basically safety net hospital funding, which we will talk about through the Hospital Global Budget Initiative. And then we got almost $700 million for workforce initiatives, some of which was student loan forgiveness, but most of which is training and certification for the healthcare workforce. So a total of $6.7 billion. Again, this is like approved spending of which normally the state would have to come up with about half of it, so $3.3-ish billion. and then get the federal match on it. But we actually got a really juicy DishP. We got $4 billion worth of approved DishP, meaning programs the state was already funding are going to be designated as Medicaid programs. And so now they'll get the Medicaid match. So we get another $2 billion of federal money out of that. Um, and of those 4 billion of DishP, most of it was the safety net hospital financing program, VAPAP. Um, and this in effect means that not only do we get to do an extra $6.7 billion of Medicaid spending, but of our $3.3 billion-ish state share, mostly the federal government is covering that for us. So we're really in the black. It was a great approval. Um, the largest component of it, yeah, I talked through this, is this health related social needs program. And, I would say I'm a little ambivalent about this program. But basically, the argument for it is sort of like if let's say you're an ER physician, you see the same patients coming in over and over again. You realize that really we're spending a lot of money treating them in the ER. But if they had, like, let's say they're diabetic, if they had healthy food to eat and regularly, then they would be able to manage their condition better. Or let's say they're homeless, they're constantly getting frostbite, but if we could house them, that we would sort of save money and address their healthcare needs. And so the idea of health related social needs, or sometimes people say social determinants of health Medicaid spending, is why shouldn't Medicaid pay for those things that would actually save healthcare money and are important to people's healthcare? You know, Another way to think about it is like as sort of healthcare mission creep, right? Where, like, sure, the state does a lot of things that are good for people's health, like providing food and shelter to them. Why should they be within the Medicaid program? Like, why not just provide those things generally? Well, the Medicaid program provides Medicaid matches. So this is a way for the state to get more money from the federal government. Um, and that's fine. I support the federal government giving us more money. I think the implementation of this program over the past 2 years has been really interesting. It involves a lot of infrastructure building. So first, you know, the state designated in each region what's called some nonprofit to be a social care network that would coordinate the delivery of health related social needs services. The social care networks go to the local CBOs and say, oh, do you do like home delivered meals, or do you do counseling for homeless people on how to find housing? Well, you can bill Medicaid for that now. The CBOs learn to bill Medicaid. There's a lot of process for that. And then we can deliver housing and food and some transportation within the Medicaid program. Great. I was really interested to learn recently that 96% of all services provided under this program in the past year have been nutrition related services, mostly home delivered meals. And so you want to think like there are a lot of acronyms here, but basically what we're talking about is New York has gotten the federal government to do a really roundabout way of funding home delivered meals. Great. The other 1115 initiative I want to talk about in detail is hospital global budgeting. And I want to talk about it in general first, like sort of as it is even outside the 1115 waiver and in other states. And then I'll talk about the specific hospital global budgeting experiment that New York is doing under its 1115 authority. So in the US, the way hospitals get paid for the most part is they get paid to do stuff, right? Like they get paid to provide appendectomies, to be there for ER visits, all that sort of thing. And this creates certain incentives. In particular, it creates an incentive to do more stuff and to do more of the stuff that is billed at high costs and less of the stuff that is billed at low costs, as we talked about last week, right? The certain things are paid better than others. An alternative way to fund hospitals would be to just give a hospital, any given hospital, what's called a global budget. And so we would say in advance, like your budget for the year is $50 million, regardless of what services you do, whether you do 5 appendectomies or 500 appendectomies, you're going to get the same $50 million. And likewise, whether you see 1,000 ER patients or 10,000. And we just want you to use that $50 million to like be there for this particular community or area and provide services to everyone who walks in. One way to think about it is that this alternative way of funding hospitals is a little bit like how public schools are funded. Right now, hospitals are funded as though if a school were funded by like every time someone got one AP calculus class, the school got $50, and then it tried to offer the right classes to attract the right students to sort of have make money at the end of the year. But in general, we just fund public schools by saying, all right, like the property taxes are what they are. They fund the school. Then whether 100 students show up or 150, that's your budget for the year. And this can be a good way of funding hospitals because it incentivizes preventive care. So like under the normal way of funding things, a hospital has no real incentive to keep people from visiting the ER. On the contrary, every time someone visits the ER, they get paid a little bit. But maybe if we provided a global budget, they would think, we have a fixed budget, but this person keeps showing up to the ER. Let's see if we can put a social worker on the case and try to keep them out of the ER and spend more efficiently. It also offers a lot of stability for hospitals, so they aren't sort of guessing at the beginning of the year whether they'll be far in the hole at the end of the year or not. And it can allow big transitions for hospitals. So if a hospital says, okay, we want to shut down our inpatient ward and convert it to outpatient, and that's going to require some renovations. It's going to take 6 months or whatever. And then at the end of that, we won't know how much we're getting paid. With a global budget, they know what their budget is and they can do that kind of thing. So this system is how hospitals are funded in Maryland, also in Canada, but more relevantly for us in Maryland. And CMS wants to encourage it elsewhere. And so CMS rolled out a model during the Biden administration of like, look, states, if you want to switch some or all of your hospitals to global budgets, we love that idea. Come talk to us. The federal government is enthusiastic about the idea. New York did a very small scale version of the idea where only downstate private safety net hospitals are going to be on a global budget. Not all hospitals, as is happening in Maryland and will soon happen in Vermont, but just a list of the poorest 15 hospitals in downstate New York. And through the 1115 process, the state is getting an extra $550 million a year to support those specific hospitals, which is a significant amount of money. And this really speaks to a typical 1115 negotiation. Basically, what happened here, as far as I can tell, is that the state went to CMS and said, look, we really need a bunch of money for our safety net hospitals. CMS went to the state and was like, what would be really cool is if you did global budgeting. And they came to a compromise where the state's doing global budgeting and it's getting a bunch of federal money. And so everyone wins. So that gives a sort of sense of what the state federal negotiations might be like. And so the 1115 waiver has other things. It also has workforce initiatives. I think this is a significant amount of money, even relative to New York State Medicaid. And it also speaks to it's the most discretionary part of the Medicaid program on both the federal and the um, state side, and so it speaks to like how the different levels of government are thinking about where we should steer healthcare. We should be investing more in health related social needs. We should be investing more in global budgeting. Um, Now all this, so this was approved in 2024, and now it's up for renewal in March of 2027. The Biden administration really screwed us on this. They could have approved it for 5 years, and I'm sure the state asked them to, and then the approval would last out to after the end of the Trump administration. Um, Instead, it's expiring in the middle of the Trump administration, and the Trump administration is going to take a hard look at this, and in particular at the overall spending. So the Trump administration might say, look, the Biden administration agreed that you had $7 billion of budget savings, but we only think it's 1 billion or something like that. And also at the specific programs. The federal government, the Trump administration in particular, has said they really don't want 1115 waivers paying people's rent, which is one of the program areas that the HRSN is doing. And so they'll probably push back on that as well. The state has already, about a month ago, applied for an extension or a renewal of its waiver. And its asks were ambitious given the Trump administration. And so expect to read a lot of news about state federal conflict over this in the coming months. Um, there are, okay, so 1115 is the, 2,000 pound gorilla of New York State Medicaid waivers. But the state, like all states, New York State also has a bunch of other waivers. And in particular, it has a handful of 1915C waivers. Those are waivers that authorize home and community-based services for a bunch of specific populations. And these are kind of like before 2011, in 2011, the state switched to mandatory managed long-term care. That was the program I called the worst program in history in class two. Before that time, the state had like 8 more 1915C waivers. Like all of the home care in the state was provided through special population little waivers. A bunch of those were consolidated into managed long-term care. And these ones that are left over are for small targeted populations that are specific. So nursing home transition and diversion waiver is for a small group of elderly folks who are at risk of institutionalization or transitioning out of institutionalization and gives sort of a richer home care benefit than the standard MLTC. Traumatic brain injury waivers for people with TBI and is similar to NHTD in its benefits. And then OPWDD is a waiver for folks with intellectual and developmental disabilities, and the children's waiver is for medically frail children. And all of these are pretty small in terms of the number of people enrolled, but except for the OPWDD waiver. So the OPWDD waiver is like the main source of things like employment supports, small group homes, home care, and home care support for people with intellectual and developmental disabilities. So for instance, if if your adult child has a developmental disability, so they can't work independently, but maybe with the support of a social worker or someone to accompany them to work, they can work a job. OPWDD waiver will pay for stuff like that. It's specific to this population. And I wanted to highlight it here because it's by far the biggest of these waivers in terms of enrollment and spending. And also because this is a really important part of Medicaid that I haven't talked about all class. Because frankly, I hope to learn more about it, but I wanted to emphasize that this exists and it provides really, really important services. So there are these waivers and then the 1115 waiver. Um, and um, and that is the waiver situation in New York State. I just want to pause there before we get to work requirements and enrollment losses, and take any questions about that fairly technical presentation. Going once, going twice. All right. I'm worried that I put you all to sleep with that, but hopefully the work requirements. Oh, I see. First of all, Heidi, I'm so glad you're on. And you asked a question in the chat or sort of made a comment about Medicaid is where the money is. Um, yeah, and that's why there's so much money devoted to help. That's why there's this interest in health-related social needs being funded through Medicaid. And I just think that's so true that like one of the dynamics going on in the background here is that the US runs a pretty austere, skimpy social welfare state, but it seems to have this bottomless appetite for spending money on healthcare, not necessarily Medicaid, but in particular, but healthcare in general. And so, if you want the federal government to spend $1 billion providing food for people, low income people, then Medicaid is the place to go. And then Steve asks, are the 1915C waivers in jeopardy, and specifically the OPWDD one? I'm going to talk about I don't think the various 1915C waivers are going to be yanked or not renewed, especially the OPWDD one. I do think that there is a threat to HCBS spending in New York from the Trump administration's accusations of fraud, and so that's something we should worry about. And I'll talk a little bit more about that at the end. Hmm.
Yeah, I just wanted to say, yeah, I mean, back when I was a welfare attorney, back before Clinton, destroyed welfare as we know it, um, I even back then I realized that, we don't have an adequate welfare system in this country. And the only like socialized systems that we have are Medicaid and also education. And it's so unfair to put all these needs, onto, education providers and Medicaid providers, but those are the only, public systems that we have. So,
Hmm.
so you can see why Medicaid I think it's great that, that this has developed. I used to be a welfare attorney. I was not a healthcare. We didn't even have healthcare health law when I was in law school. But,
Yeah.
it's like we don't have welfare law anymore. So, that's the way it is.
Yeah. Yeah. 100%. Um, Don, it's a great question what the worst case scenario is with the 1115 renewal. Uh, I think, you know, I mean, they're I think rolling it over without any money would be the worst case scenario. And so like we wouldn't lose like the managed care authorization and stuff like that, but we just wouldn't have any funding for the hospital global budget stuff, wouldn't have any funding for these health related social needs. And I think there'd be a big question of like what if the state had to pay for that stuff, how much would they pay? I think it's just going to become part of the larger budget crunch in New York State. Um, and yes, Heidi, totally agree with you. It's interesting. You can think of sort of healthcare hospitals and also jails, I think, as like something one of the ways the US pays anyway for the welfare it's not willing to give in better ways. So I want to talk sorry, I'm realizing I'm a little behind my pace here. So I want to talk about work requirements and coverage loss from the reconciliation bill that passed last summer. I expect coverage loss. Coverage loss has already started to happen. On July 1st, 450,000 New Yorkers lost essential plan coverage. I'm going to talk a little bit about that at the end. And then the big thing that is looming in the future is Medicaid work requirements. So this has been a longstanding goal of conservatives across the country to impose work requirements on the Medicaid program so that adults enrolled have to demonstrate that they're working or get kicked off. Um, the uh, the Trump administration finally achieved this last summer, and work requirements are due to be imposed on low-income adults in the program, the ACA expansion population, beginning January 1st, 2027. Um, and estimates of how many of them might actually lose coverage are very, very wildly because this is a really unprecedented thing. We've never tried imposing work requirements on Medicaid at this scale in a program the size of New York. And so, anywhere between, I would say, 500,000 and a million people out of the sort of 5.4 million-ish people on health insurance Medicaid could lose coverage. And estimates vary. This same population will also be subject to another set of red tape bullshit, 6-month redetermination. So I don't want to get too wrapped up in the details of all of the exclusions and exemptions here, but the one thing to understand about the Medicaid work requirements is there are a number of ways to qualify to demonstrate compliance. One is to work 80 hours per month or do 80 hours per month of community service, or to be enrolled in college, or to earn the equivalent of the federal minimum wage for 80 hours, which is only about $580 a month of earned income. So the fact that the New York State minimum wage is so much higher than the federal minimum wage actually provides some advantage there. There's some stuff. Also, many people are exempt from the work requirements. Parents of children under 13, people who are pregnant, people who are participating in a substance use disorder program, people who meet a very narrow definition of being medically frail. And then the state also has optional ways to exempt people, including people who have an inpatient hospital episode in the course of a month can be accepted from the work requirements. So, with all these ways to comply and exemptions, most experts believe that the overwhelming majority of Medicaid enrollees already meet these requirements. Like, basically, um, you know, people are, we have a very restricted welfare system in this country. So there are very few people, like, you can't sit around on the couch not working as a healthy young adult because you can't afford a couch on $0 a year. And so the vast majority of people who are subject to these work requirements are objectively meeting them, but this creates a hoop people have to jump through every 6 months to stay on Medicaid. If they hit a snag, if their form gets lost in the mail, if they move too often and they miss a letter, they are likely to lose coverage anyway. Um, and the city's experience with SNAP work requirements so far is that the most vulnerable to losing coverage are actually young single adults. One suspects older people with sort of more, pay more attention to snail mail, like might be more on it, but it's young adults who are really likely to lose benefits, but everyone is at risk. Um, a big open question about implementation of these work requirements is that the New York State Department of Health is going to work very hard to minimize insurance loss. And in particular, the most important thing the state can do is have a good system of ex parte verification. So the ex parte means you're verified automatically without having to intervene because the state can somehow tell that you qualify, can tell that you have a child who's under 10 or under 13, or that you have income greater than you need in a given month. And so the state is building systems to sort of check tax data, to check, college enrollment data, all that stuff to sort of see who is exempt automatically. But no one really knows how well this will work and how many people, because they're in a non-traditional system. Maybe they're a gig worker, or they're working for an employer out of state, or they're a seasonal worker, won't be picked up in this and will need to actually sort of separately prove that they're eligible or lose coverage. Um, uh, and and so and just to say it right, like the point of this program is to kick a bunch of people off Medicaid. Um, and so the Trump administration, for instance, there was some hope that the exemption for people who are medically frail could be used to protect people, but the Trump administration issued regulations a couple of months ago that really, really narrowed that. So only people who are so severely ill that they're totally unable to work will qualify for that exemption, and they will need a note from a doctor saying that. And so this is, the goal of the policy is to kick folks off. And I want to talk a little bit about sort of just how little that policy makes sense, because I think it makes some interesting points about healthcare and health insurance. So an important thing to like really wrap one's mind around about health insurance is that most healthcare spending goes to people who are pretty sick, like ranging from they have a heart condition and need to be on medication to like they're literally in the ICU. Um, there's a rule of thumb in healthcare, which is the 80-20 rule, that 80% of your population accounts for about or 20% of your population accounts for 80% of your spending. Um, so in other words, the other 80% of your population does not cost that much. And so I think there is this idea floating around conservative policy circles that like, oh, sure, like maybe Medicaid should cover sick people, like people who have serious problems, old people, but we shouldn't be spending our tax dollars to pay for health care for some healthy 25-year-old who's just smoking pot on his mother's couch or whatever. Like that's ridiculous. But the thing is, like, it costs almost nothing to cover that person. So there's like, we're not going to save any money by stripping that person's health insurance. They probably don't even, when I was a 25-year-old in that situation, I didn't even get primary care checkups. It costs nothing to provide healthcare to me. And then if that person gets sick, then like let's say they get hit by a cab one day, then they will go into the hospital and then they will immediately be back on Medicaid. They'll qualify for an exemption because they have an inpatient hospitalization. And likewise, if that person has a heart attack, they'll be medically frail, they'll end up on healthcare. So most of the money that we were going to spend on this population we will be spending even if we kick them off Medicaid because they'll get back on Medicaid when they get sick. That doesn't mean the policy isn't really bad. It makes it even worse because we're not even sort of saving much money or having any advantage that way. We're just making it a bureaucratic nightmare to stay on Medicaid. We're forcing state Medicaid agencies to spend a year and a lot of money on crash implementation programs. And the result of it will be basically like not a cheaper Medicaid program, but merely a more broken, more complex one that provides less peace of mind to fewer people. Um, I saw Maureen asked how much will it cost states to implement and police work requirements? Will it cost more than it saves? So my view on this is that it will cost about as much as it saves overall. It's important to say how those savings break down between the state and the federal government. Work requirements apply specifically to the ACA expansion population, sort of mostly childless adults under 138% of poverty. And that population, because of the ACA, is actually paid for 90% by the federal government. So instead of a 50-50 Medicaid match, it's 90-10. So any savings that accrue from this, from kicking people off Medicaid, are going to basically exclusively flow to the federal government, not to the state government, whereas all the work of implementing it is falling on the state government. So it is a cut to states, and it's also a cut to federal healthcare money flowing to in-state providers. So work requirements are a really big part of the insurance loss that we're facing next year. I'm going to just go back to this graph and show like those insurance losses are projected to be really severe and to reverse almost all of the progress we've made since the implementation of the ACA. Before the ACA was implemented, our uninsurance rate was, around 11%. We got it all the way down to around 5%, and we're headed back to 11%. So it's a real tragedy. A lot of that is work requirements, which are set to cause between 500,000 and 1 million people to lose coverage. The other really big component of that is the essential plan. Um, um, yeah. Judy asks a very fair question about my 80/20 rule calculation, which is like, okay, sure, like even if someone doesn't use healthcare in New York State, if they're on Medicaid, they're on managed care, and whether they use healthcare or not, whether they go to the doctor or not, we're paying a capitation payment to managed care companies to provide health insurance for them. So if we kick them off Medicaid, well, that capitation payment will be saved. It'll be saved by the federal government, mostly by the state a little bit, whether they're a high healthcare user or a low healthcare user. That is right. I think what I would say is that I'm still right about this because you got to think. if I'm right that we're kicking off disproportionately relatively healthy Medicaid enrollees, what that means is that the average, so we're kicking healthy Medicaid enrollees out of Medicaid. That means the average Medicaid enrollee will be sicker, which will raise the premiums we have to pay those managed care plans. And so, like, it won't show up as sort of the savings won't show up because they'll be eaten up by an increase in the cost of insuring the remaining Medicaid population. But thanks for asking that. That's an important question. Um, so a lot of the coverage loss is down to work requirements. One component of the coverage loss is due to the essential plan, which is not Medicaid, but it gets confused with or talked about in the same breath as Medicaid so often that I feel like we should talk about it in this class. And the coverage losses related to the essential plan have already happened. In New York State, on July 1st, 450,000 New Yorkers lost essential plan coverage. I want to talk about the essential plan because it is like, it's a real tragedy that um, the Trump administration cut it and that the state legislature and the Hochul administration didn't do more to protect it. Because for my money, it is like the best healthcare thing that New York State is doing right now. It's like nationally innovative. It's so cool, and it is still around. It covered at the beginning of this year. It covered 1.7 million New Yorkers. Now it because it was cut, 450,000 people lost coverage, but that still leaves 1.25 million New Yorkers on the essential plan. Um, and it's a really, I want to sort of talk about what it is and how it works, and then how the Trump administration cut it and where that leaves us. But I want to try to do this really, really quickly. Um, I'm trying to think about how to do this as quickly as possible. Basically, the background here is that the way the ACA works in most states is roughly that up to 138% of the federal poverty line, you're on Medicaid. And then above 138% of the poverty line, if you don't have employer insurance, you go on the individual market, right? And you get individual market insurance, and you get a premium tax credit that depends on your income. And I had the experience when I was freelancing in my 20s of going on the exchange and being like, wow, this health insurance is really expensive and sucks and it's terrible. But that was because I was like relatively high income for the exchange population. Most of the exchange population nationally, and the individual market, if
You're
you're
breaking, you're breaking up.
like a white, you might give this a. Oh, I'm sorry. Shoot. Um, we'll see if that's better. I'm so sorry. Okay. Hopefully this works better. If not, I don't know. Um, come off mute and tell me if I'm breaking up again. So, so in yeah, in most of the country, low income people who aren't poor enough to be on Medicaid go on the exchange and they get very, very heavily subsidized insurance where the federal government pays 90% of the costs. In New York, we do something different, where instead of letting those people go on the exchange, we um, take those premium tax credits that cover 90% of the costs. We package them and we provide basically like a Medicaid-like healthcare plan to those people. And because because the government is so good at running healthcare programs, we are able to do this much, much more cheaply than private insurance. So the result is that we provide much better than individual market insurance at a much lower cost to individuals and to the state. So in other states, if you're 175% of the poverty line, you might be on the exchange paying $150 per month, and you might be buying a silver plan that has a $2,000 deductible. In New York, you are getting free health insurance that has a $0 deductible, and you're getting it at no cost to the state because the state is using that premium tax credit money to fully fund that for you. And so EP is this like very, very efficient way to provide health care, and it was cut quite dramatically the by by the reconciliation bill, and the result is that and the state decided to respond to those cuts by lowering the eligibility threshold from 250% to 200% of the federal poverty line, and that caused 450,000 people to lose coverage on July 1st. The essential plan is still around for everyone under 200% of the poverty line, but the coverage loss from that element from the essential plan cuts has already happened. And Yeah, I have a lot more to say about the Essential Plan, my favorite New York State health program, but I'm realizing we only have about 10 minutes left, so I wanna make sure to pause for to stop for questions about work requirements and HR1 impacts. Okay, we have a vote for hearing more about the Essential Plan. I love it, so I would be happy to talk about it. Um, all right. Um, so the Essential Plan, again, the key thing to understand about it as background is that it is funded by the same mechanism that provides premium tax credits in other states on the exchange. But because it's a more efficient way to provide health insurance than exchange insurance, it actually we can provide much better coverage and at a much lower cost to the state and the federal government. And because that's the case, the the essential plan actually operated at a surplus for the first 8 years of its existence. It existed from 2015 to 2023. Every year, the state would go to the federal government and get the premium tax credits, and then it would provide, hundreds of thousands of New Yorkers with free zero premium health insurance, and it would have money left over at the end of the year, even after it had provided this health insurance. And because it ran at, basically a profit, it had a surplus, it started accumulating money. Every year, there would be $1 billion extra lying around in the essential plan that the state couldn't spend. In the Under federal law, the state wasn't allowed to just spend this money on something else. And so, it had to be spent specifically on the essential plan population. And so, the essential plan basically accumulated a large bank account, a $10 billion trust fund. And the state decided what it was going to do it was going to expand eligibility for the essential plan further, up from 200% to 250% of the federal poverty line in 2024. And it was going to spend the surplus on covering that higher income population and on also higher provider rates to hospitals. It almost doubled the rates it paid to hospitals. And then and so that was the status as of 2024. It was this very successful program that was expanding. And then what happened with the One Big Beautiful Bill Act was the One Big Beautiful Bill Act basically cut premium tax credits for lawfully present immigrants. And there were 750,000 essential plan enrollees who were lawfully present immigrants. Lawfully present immigrant basically means they're not undocumented. And so these are folks who are green card holders, who are on H-1B visas, who are on refugee visas, all sorts of statuses, but not undocumented. Undocumented immigrants are not eligible for the essential plan, but these lawfully present immigrants were. The One Big Beautiful Bill Act across the country cut premium tax credit eligibility for lawfully present immigrants. And in New York, that meant cutting essential plan funding to the essential plan group. And this caused the essential plan to lose almost half of its federal funding, which does not mean that the lawfully present immigrants are necessarily kicked off the essential plan. They are actually still on the essential plan. It just means that the premium tax credit federal funding that we were getting to cover them is no longer coming. And so because they were responsible for so much of the funding, the loss of those premium tax credit equivalents destabilized the whole plan. And so so the state government basically was looking at a program that was spending about $14 billion a year and was at that time getting $14 billion a year of federal funding, and suddenly had lost $7 billion a year of federal funding. So the question was, what were they going to do? And they did two things to preserve the essential plan. First, they dramatically cut eligibility down from 250% to 200% of the poverty line. So all of the 450,000 people in that 200 to 250 group who had gotten coverage in 2024 have now lost coverage as of July 1st, 2026. But even with this cut, the essential plan was still operating at a deficit. And so the other thing the state did was it decided to go back and access that $10 billion surplus that had been accumulating for the first 8 years of the essential plan. And by accessing that surplus and gradually spending it down, it can essentially operate a health program that now has like a run rate of about $11 billion a year, but is only getting about $7 billion a year of federal funding. And so what that means is that we're like spending down a finite bank account to keep the essential plan going, and the bank account will run out, according to the state, in 2030, at which point we'll have to decide either to put state money into the essential plan or to wrap it up and send everyone to the exchange. That's assuming we don't have changes to federal law that are helpful, which is what I would hope. And so the essential plan has already been cut and faces further risks. Um, there, the last thing I'll say about the essential plan, there's a wide, the people who lost essential plan coverage are mostly eligible for individual market coverage, but that coverage will be really dramatically more expensive. They're now getting free coverage. They'll have to pay about $250 a month for much, much worse coverage. And so many of them will become uninsured, and even the ones who don't will face dramatically higher health insurance costs. Okay, so that's what I have to say about the essential plan. Sorry to race through the end here. I'm seeing a question from Leon Delaney. Do other states have something similar to the essential plan? The answer is only Minnesota does, and it's much smaller. But before the reconciliation bill, Oregon was looking to implement it, and actually, I recently saw that Francesca Hong, who's running for governor in Wisconsin, is also running on doing a Wisconsin essential plan. It's really an example of really innovative and cool New York State policy that worked very, very well. And you know, I think in New York policy circles, it's kind of viewed as, well, it's great as long as the federal government is paying for it, but since the federal government is no longer paying for it, we can't afford it. But I would say the essential plan is actually a really efficient and smart way to provide health insurance. And even if the state has to kick in some funding, I think it is a really high priority to protect. Okay, and I can stick around for 10 more minutes to answer questions. But for people who may have to go right at 8:30 or may just be hungry and want dinner, etc. Thank you all so much for attending. This was really, really fun for me to do, and I'm going to send out a feedback form. I would be really, really delighted to get feedback, positive and negative, because this is a class I definitely intend to offer again in the future. So look out for that. And thank you for coming.